investigation, hemoglobin 6.8 gram per deciliter, PLC count 6,600 per cubic millimeter, platelet count is 1.6 lakh, ESR is raised, and MCV, MCH, MCAC is decreased with serum ferritin borderline lower level, reticulocyte count is 0.5%, ANCA negative, ANA negative, and viral serology like HBs antigen, anti-HCV, HIV all are negative. On urine routine microscopy examination, albumin positive, sugar positive, POSL is 23 for high power field, RBC is negative, and plasmodium virus of falciparum antibody negative, blood culture no growth, and urine culture is highly sensitive for the significant infection of E. coli, and it is sensitive to amikacin and gatticlopsacin. Further investigation during hospitalization, then cell anemic and patient's ESR is raised with blood group O positive, serum triglyceride, cholesterol, HDL, LDL, VLDL all within normal limit. Then LFT, serum bilirubin is 0.4 milligram deciliter, total protein 5 gram per deciliter, albumin 1.4, and globulin 3.6. All liver enzymes are within normal limit. This is the chest X-ray of the patient. Here views showing patchy non-homogeneous opacity bilaterally, both lower and middle zone, with obliteration of the both CPM groups. Then sputum for AFB, no organism found, gram stain negative, no growth in culture. Fluid analysis is exudative type, transitive with urine. Again the urine POSL persists with albumin positive, sugar is nil, urine culture sensitivity after antibiotic therapy, no growth. Then microreal real-time PCR urine negative. Then urine culture for the mycobacterium was negative. 24-hour urine protein 50 milligram per 24 hours. Coombs test direct is positive. Coombs test indirect negative with ANA negative. Again RF vector negative, anti-CCP negative, and both IgG and IgM anti-phospholipid antibody is negative. ECG, there is sinus tachycardia with no STP changes. Echocardiography finding, left ventricular ejection fraction is 62%, all others are normal. On USG, there is obliteration of this, there is minimal fluid in the CP angle with minimal fluid in the pulse of Douglas, all others are normal. This is the ultrasound finding. CT scan, on CT scan of the thorax, there is bilateral pleural effusion with basal collapse with mild cardiomegaly. CT scan. Then we do the bone marrow. Then bone marrow finding is
CT scan just normal.
Mild.
Then carry.
This is bone marrow finding, all are normal. During course of hospital stay, patient's fever continue and patient become more hypotensive and she required antihypertensive drug. Then edema develop all over body with weight gain of 6 kg. Then she shifted to ICU for respiratory distress and hypotension and shock. Then further investigation, ANA is positive, anti-DSDNA is positive, and 24-hour urine protein is 1 gram per 24 hours. Then renal biopsy report. In the renal biopsy report, glomeruli showing diffuse increase in mesangial cell with endocapillary cell proliferation and scattered neutrophil. One of them shows cellular crescent, tubule or interstitium, hyaline and granular cast in the lumen with patchy neutrophilic infiltration, no tubular atrophy, vessels, arterial wall hyperplasia, no vasculitis, no lumen thrombosis. On immunofluorescence study, diffuse or global fine granular deposit in the capillary region with IgG, IgM, C3, C1q. Then the final report, it is a lupus nephritis class 3 active. This was my final diagnosis.
Again,
Why the first case was negative?
That is the
I appreciate again investigational problem because in our first differential diagnosis we have taken collagen disease in our list. Okay, and the what is the symptom and sign? Yes, bilateral transmitted pleural effusion with normal first injection with normal urinary protein, normal serum albumin.
No,
with
normal, low.
1.4. Only serum albumin was low and ANA and dsDNA both negative. So in this situation one may exclude SLE, but we can't pinpoint any other diagnosis. The most common cause of bilateral translative pleural effusion is the congestive cardiac failure. But ejection fraction is fairly normal. So this is the situation that we have to order again a done test.
What is the first method of doing ANA and second method of doing it? Is the same method? Yes. I think this is the most important part is lies there. That if you send the blood to a laboratory where everything can be done, except the good way of doing ANA will be negative.
Can we be the duration? 4 months of duration leading to positivity later on?
That can. But what is the method of doing ANA?
Yes.
What is the method of doing ANA?
Same the Elizabeth gap is the 2 months. Duration of it is
F2 cells, no F2 cells. So this is the real issue, na?
What happened?
If you do not use F2 cells, you might miss the early phase of lupus. This is the real issue.
We do agree, but this is the method what we have.
No, I agree, but this is the
This is the method what we do. We have not this is our
Problem is that initially whether the diagnostic dilemma was there, and when she has a full-blownly hepatorenal like complication, the patient has collapsed. We have put in central line for 7 days, monitored CVP, fluid balance, almost 10 kg of this, and after we show the data, after the whole treatment and everything, yes, patient treated with the methylprednisolone and cyclophosphamide, and after next protein so this was the data, sir, after treatment. Everything has came down to normal.
no. But
One important point, all the investigation coming benign, that there are no ANA, no dsDNA, and the
2 months gap is
but one thing is very important, all the time she has ESR high.
yes.
So this is this is not matching. A patient having a high ESR, but we are not pinpointing a disease that must be missing something. And here the missing is the physician have got the disease correctly, but due to laboratory error or laboratory.
Same thing we are not the 2 cells from the same laboratory. We have not the AN and anti-dsDNA with the 2 months gap. Initially it was
What I mean to say that if a patient of reproductive age group, young female,
Yes.
the patient has got multi-organ disease,
Yeah.
and whatever happens to your laboratory, don't treat the laboratory things. You more on your clinical suspicion, repeat the test again and again. And second thing, I don't believe that it's a case of only lupus nephritis. I think it's a lupus plus lupus pulmonary involvement. So there are so many things, and because and there is CRP is positive. So how do you explain? Most of the time, lupus disease causes normal CRP, even during flare. If CRP is there, some more infection is important. But one urinary infection has been detected,
UTI
so
was
that
there
should
and
be
any
ruled out.
I'll have to take it with a little pinch of salt, accept the diagnosis of visceral nephritis. If I can remember, 2 cases were presented at Medica were presented, which looked like this because the patient did not have the criteria. I don't know what is the criteria for this. Maybe some immune complex mediated glomerulonephritis, which has responded to your this immunosuppressive agent.
Yes.
Because I think patient ANA negative, anti-dsDNA negative.
Second set
Second
positive.
time negative.
Positive.
So I think one has to think like that, whether it's purely reflux or some other immune complex mediated problem causing this nephrotic and pulmonary involvement. So I think that one is
Basically,
different causes.
hepatorenal pulmonary
Pulmonary
syndrome.
Yes.
And first negative, second negative. Second point was some serum ferritin level initially was low, showing iron deficiency like anemia.
Yeah.
And later on Coombs was positive. So these are the two enigma of the opposite spectrum. And when full-blown developed, then the whole picture was that patient clinically collapsed and after treatment again recovered. That's
So I think the patient had some pulmonary syndrome also.
Yes.
So it could be pulmonary renal syndrome. And there are several causes of pulmonary renal syndrome. So I think one has to include those other causes also.
Thank you.
Thank you.